Okay, the next presenter we have is Professor Scott Bell, who's the Executive Director of Research for Metro North and a Queensland Health Research Fellow. He's interested in the clinical impact of clonal Pseudomonas aeruginosa and cystic fibrosis.
So thanks very much, everyone. And I guess to echo David's and earlier speakers, congratulations, Jason and Jeff, and to the whole team for a fantastic opportunity and initiative with the CRE. I don't think there's any chance, even when my foot heals, that I'm going to beat you up the up Mount Kufa next year, David, but I'll give it a try. And I can also report that I had less than 24 hours of prophylactic antibiotics when I had my surgery 6 weeks ago. I'm going to talk about a chronic infection. I think most of the discussion today so far has been about acute infections, and one that is increasingly problematic for patients with cystic fibrosis. But before I do that, I just want to make a couple of points, and I think the collaborations that happen with this CRE are really a fantastic opportunity for us to watch and see how that happens. I've taken on this new role as the Executive Director of Research for Metro North, and I did it largely because for what I see in the 20 years I've been in Queensland Health, both the board and the current leadership of Metro North are the most visionary in terms of focusing on how we can improve clinical care through translating research which we undertake ourselves and we embrace and collaborate with others. So non-tuberculous mycobacteria are within the Mycobacteria group, and there are over 100 different species, probably many more than that. The ones in blue represent relatively common human pathogens, and this is an old style of differentiating the different groups, the Runyon classification. The blue ones particularly can cause infections in immunocompromised hosts, but particularly those with significant structural lung disease, and those in particular Mycobacterium kansasii, the avium complex, which traditionally are relatively slow-growing organisms in the laboratory, and then also Mycobacterium fortuitum, and particularly Chelonii and abscessus, which are classically rapid growers within the laboratory. Both the identification of this organism in patients and its clinical significance is growing worldwide. And it's not entirely clear why that might be. Because it's a notifiable disease in Queensland, one of the only jurisdictions internationally that actually has NTM as a notifiable disease, we can follow the rates of NTM much closer than in any other part of the country, for instance. And even though we can't directly compare the international data, which is around clinically significant pulmonary infection, in Queensland here we've reported patient isolates. These are probably in 60% of the cases clinically significant. So the rates are at least double in Queensland to what they've been seen in contemporary years in other parts of the world. These are some data from my colleague Rachel Thompson, who many of you will know, and she's taken two snapshots cross-sectionally over a 6-year period. And these data are a little old now, but they do demonstrate that some of the rapid growers are rapidly growing in our population. It's a non-pigmented, rapid-growing mycobacteria, which usually grows in the laboratory in less than 7 days. Its taxonomy has changed over the years. It can cause soft tissue, skin, and even disseminated disease in patients with immunocompromise. But it's really the chronic disease that occurs in patients who are apparently systemically immunocompetent but may have local immune compromise that results in significant dilemmas in patients with chronic lung disease, particularly those with cystic fibrosis. The survival of people with cystic fibrosis has increased dramatically. As you can see, our inputs are pretty stable at our clinic at Prince Charles, but the total number of patients is growing very rapidly. And as you can see, this has had a significant impact on the way we deliver our care at the hospital, and also some challenges that relate to the diverse population spread in terms of where they live and how you deliver this sort of care. One of the reasons for the increasing survival amongst several is there been a much more aggressive approach with antimicrobial therapy. And as a consequence of intensive eradication treatment, particularly in children and increasingly in adults who don't have a history of chronic Pseudomonas, rates of chronic Pseudomonas infection are decreasing. And amongst other microbes, NTM infection rates are increasing. And in many parts of the world, upwards of 15% of patients will have chronic NTM infection. Mycobacterium abscessus as a proportion of the NTM cases varies. In Queensland, it's approximately 60%. And about half the patients will have clinically significant infection. Two papers in the last year have demonstrated increasing rates of NTM infection. On the left in Denmark and other parts of Scandinavia, and on the right in Israel. And they've raised a couple of interesting points. Geographical variability in Israel was thought to be associated with those patients receiving their care at the larger centres. Heightening awareness, maybe, for diagnosis, may be one of the reasons. So we're actually diagnosing it more often because we're checking for its presence. Or secondly, whether there's a possibility of cross-infection, an issue I'll return to shortly. That didn't seem to be the case in the Israel study in terms of the intensity of and the lab processing of sputum samples. However, there was regionalisation, and particularly in those parts of Israel where the coastal cities where the climate was hot and humid, not dissimilar to the Queensland tropical climate. So many factors may contribute to the increasing NTM rates. We know that the younger patients with milder disease are more likely to get Mycobacterium abscessus, contrary to what you might immediately think. Those patients with milder CFTR mutations may be at more risk of getting NTM than those that don't, particularly for the rapid growers. Diabetes potentially having an impact on systemic immune compromise may be a factor. We also know that there's something around the ecology of the airway and the local microbiome. Those patients with NTM are more likely to have co-infection with Aspergillus, Stenotrophomonas and Staph aureus. Associated with our increased aggressive approach to antimicrobials, there's also been an increase in the use of macrolides, and clearly this may be a factor contributing to increased rates of NTM. We think about 50% of our patients who acquire NTM will get clinically significant infection. Perhaps more in those groups who have Mycobacterium abscessus, which is 60% of our patients. This organism is innately resistant to antimicrobials, and we know that the morbidity of treatment is significant. I can't think how we could give standard doses of tigecycline, let alone double doses that David was advocating. We also know treatment response is unpredictable, and the presence of Mycobacterium abscessus impacts on whether you can be pushed forward for a transplant because of the potential for disseminated infection after transplantation. Geography seems to influence rates of mycobacteria. If you live in tropical Queensland, north of the Tropic of Capricorn, you are much greater risk of mycobacterial infection than if you live in the subtropical parts of Queensland or northern New South Wales. And we know this from earlier studies from Rachel Thompson and also from the US, that there are hotbeds of mycobacterial infection, particularly Mycobacterial abscessus. And this particular area around the Whitsundays, where we have pristine waters, does make you wonder why. And perhaps the next slide will help in understanding that the weather may have an impact because it's not always as pristine at all times in the year. And this may be one of the factors that lead to increased rates of NTM in far north Queensland. We know that mycobacteria, non-tuberculous mycobacteria, can be aerosolised from natural waters and in fact can be transferred from the sea water to air by natural processes. In other words, monsoonal rains, it comes out of the soil and also out of the water and potentially aerosolised by susceptible hosts. We also know that non-tuberculous mycobacteria is found in potable water around the world, including Queensland, and also that it can be grown from the biofilm inside your shower heads and also from the aerosols of your shower head water. Rates of mycobacteria in our clinic have increased. The prevalence now is approaching 10% in a setting of reducing rates of chronic Pseudomonas infection. We wonder whether the drought period during the 5-year period in the mid-2000s to the late 2000s, and then many of you will remember the monsoonal rains and floods that we had throughout Queensland and particularly in South Queensland, may have impacted on our rates of NTM infection. More controversially is the possibility of cross-infection. This is something that has been put forward by the Seattle and Cambridge groups, but we now know in an international collaboration, which Queensland Isolates provided 25% of this set, that there are shared strains that are also present in other parts of the world. Now, we don't really understand at this stage how this might occur, but it may be from the natural environment, but it also could be as a result of direct or indirect person-to-person carriage of the organism. So why is NTM colonisation and disease increasing? Well, there may be evolution of the pathogen. It may be becoming more persistent and more virulent. We're also aware that our clinics are more aware about NTM and potentially our screening, and there have been improvements in methods of detection, particularly non-culture methods. And we also know that in our clinics we're treating patients, particularly younger patients, with more aggressive eradication programs, and we're using more macrolides. And it may be in the process of eradicating Pseudomonas and other bacterial infections, we're providing an opportunity for other opportunist organisms such as Mycobacteria to fill that space. Patients are increasingly surviving for longer periods, and our hospitals are overrun with adult patients with CF, and the possibility of person-to-person infection must be considered. We have an older population, although not an aged population, and maybe factors around the immune response to this infection need to be considered in more detail. And then, of course, there's compelling evidence to suggest that the environment and its particular environmental conditions may increase risk of infection. This led us to put a proposal forward to the NHMRC early last year, which we were fortunate enough to be awarded, a 5-year grant, to do 3 studies. Effectively, the first study is to look at prevalence and incidence, host, microbiological and environmental factors that are associated with NTM detection and disease, but particularly focusing on the difficult one, that's the Mycobacterium abscessus. This study involves 21 sites and we'll be recruiting in the next couple of months. The earlier study demonstrating the potential for cross-infection and global clones ironically may impact in a positive way on recruitment for patients and clinics to be involved in this study. We had no trouble in recruiting the 21 studies to participate in this because it provided an opportunity for them to better understand not only the epidemiology and the potential clinical impact, but also provide opportunities for new infections. In addition to that, we'll be looking at the microbiota and the whole genome of the abscessus organisms in the first instance. This led recently to some discussions with a number of people, our immunology colleagues at QRMR, and also with Jason's group, to ask the questions around, well, what do we need to understand about the immunology, but also in terms of drug delivery. Earlier this year in Thorax, international guidelines for the management of NTM in CF were published, and there are 48 guidelines, 48 recommendations, and these are just 3, and I focus on a couple, and that's the use of these potentially toxic drugs for long periods of time, both in an initial intensive phase and then a consolidation phase. And interestingly, there's very little known about how to monitor direct susceptibility testing, and this is an area that further research is required. I hesitated to put this up with so many infectious diseases luminaries in the room. These are the sorts of typical therapies that are used in some parts of the world to treat the rapid growing organisms. And they do work, at least in the short term. You can clear smear and culture positive sputum, but they're incredibly toxic. They're incredibly expensive regimens to take, and they have very significant morbidity. So we need to understand better the drugs we use. We know from limited studies with a number of drugs that pharmacokinetics in people with cystic fibrosis are different for age and weight matched people who don't have CF. There's evidence of increased volume of distribution and more rapid clearance of many of the drugs. And also there's the issue of how do you actually penetrate thick inspissated secretions, either through the airway delivery or systemic delivery of antimicrobials. Gastrointestinal disease may impact on absorption. I said before that we see co-infection with aspergillus, and many patients will be on azole antifungal therapies to control difficult ABPA. It's almost impossible to use rifampicin with itraconazole and get meaningful levels of the azole antifungals. An impact of the success of CF has been lifelong, very significant burden of systemic aminoglycosides, which is having an impact on renal disease in people with cystic fibrosis. And then finally, juggling a very complex regimen, and you've just heard part of it, the aerosol and airway clearance aspects and many of the other disease morbidities, including diabetes, have significant impact on the ability and the acceptability of therapy. And many patients who embark on the journey of treatment of abscessus really desperate to pull out after a few months. So I think there is a role for the CRE reduce and chronic infection. You can help us redefine antimicrobial use and reduce resistance and perhaps improve the effectiveness of our therapy in a growing population of patients who are frequent flyers in our hospital, who have difficult infections, who suffer significant morbidity, and yet the impact of not adequately treating an infection is significant. It can rule out the possibility of transplantation, for instance. We have limited availability, and we have a national platform. In managing patients with NTM, we always have to think about, and I think this is a recurrent theme that's come up today, is about the patient benefit versus the societal cost in the very intensive approach to this particular infection in this group of patients. Thank you.